everybody, to another episode of Hybrid Healing Hour. Today, we are going to be talking about bariatric surgery, and we have a special guest with us who is a general and bariatric surgeon, Dr. Heba Schiller. Welcome to our podcast. Thank you for coming. And why don't you go ahead and tell our audience a little bit about yourself and how you got to where you are today?
Absolutely. Thank you so much for having me. It's a pleasure. My name is Heba Schiller. I'm originally from Arkansas. I did all of my undergrad and medical training in Arkansas. And then I came to Florida for all of my residency training and fellowship. So I did 2 years at the University of Florida, and then I completed my residency at Florida Atlantic University in general surgery. And then I joined my current private practice group. And then I took a year to do a fellowship in MIS, which is minimally invasive surgery, and bariatric surgery. Wow. And then I rejoined my group.
Awesome. So, a lot of training.
Yes, a lot of training.
And local.
Yes.
So that probably helped you out a
Absolutely.
little bit there, knowing how we do things down in South Florida.
Absolutely. And, loved the area when I moved down here and decided to do my additional training down here and stay in the area.
Yeah.
Absolutely.
So I think this topic is very timely now because amid the rising concerns about the potential long-term costs of using the GLP-1s, Ozempic and tirzepatide, semaglutide, to treat obesity, some insurance companies are actually now making it easier and giving better access to bariatric surgery. Is that what you're seeing in your practice as well?
Insurance has definitely been a big hurdle for getting bariatric surgery. So that is great to hear. We've actually seen a slight downturn because of the new GLP-1 agonist in the referrals for bariatric surgery. I think as we get more data and long-term evidence on the efficacy and long-term effects and side effects of the medications, I think there's going to be a rise and fall and then a steady state of where the medications and the surgery, I think they're going to work hand in hand.
And I think that's a good approach. So our biggest frustration has been that we've always considered obesity to be a chronic medical condition and not a condition of appearance and behavior. But unfortunately, the insurance companies and the stigma today is, it's just cosmetic. It's just looks.
Yes. And I think that the more education we can get and advocate for our patients with the insurance companies, it'll be beneficial to everyone in the long term. I mean, obesity is an epidemic in the United States, and it seems to only be increasing, not decreasing.
Unfortunately.
And so I think, advances in medical management, advances in surgical management, those are all just so necessary for our country.
And now it's starting to be a worldwide epidemic.
Yes.
Many countries that never had obesity before are starting to catch up.
Yes, absolutely.
So why don't we go ahead and just dive right into talking about education. So tell our audience, what is bariatric surgery? When people hear this term, I think there's a few different ideas that come to mind.
Yes. So bariatric surgery is weight loss surgery. It's the surgical management of obesity. There has been multiple different procedures that have been used for weight loss. And as we develop and shift in evidence, these procedures rise in popularity and then fall in popularity. The gold standard of bariatric surgery has been the roux-en-y gastric bypass. There have been other procedures like the gastric banding that has kind of fallen out of popularity, but it was very popular maybe 10, 15 years ago. The gastric sleeve came into popularity initially as the first step of a two-step procedure. And then with the realization that there's significant weight loss just with the first step, which is the gastric sleeve, that the second procedure was not necessarily necessary. And looking at the risk and benefit profile, it had a much lower complication rate as well. And so about, I would say, average 10 years, it's gained and continues to gain popularity as a more commonly done procedure.
Can you explain what exactly a gastric sleeve is?
Yes. So the gastric sleeve is a surgery where about the outer 2/3 of the stomach is removed. It is stapled off. And if you imagine, your stomach will then look like what we call a sleeve, but a banana is a more accurate description. And so that
you're basically only have the upper 1/3 of the stomach?
It's the medial 1/3. So I would say it's done longitudinally.
Gotcha. Okay.
Yes.
Perfect.
So you're keeping about 1/3 of your stomach. The benefits of a sleeve gastrectomy are it's a restrictive procedure, meaning that it restricts the amount that you can eat. An additional benefit is that there's a hormone, ghrelin, that is the hunger hormone. And it's the outer portion of that stomach that stimulates that in the brain. And so when you remove that portion, you also feel less hunger. So you don't feel like eating, and you're only able to eat less. And that's really where the weight loss comes from in a gastric sleeve.
And talking about hormones and the endocrine system, I've always found it fascinating that with the roux-en-y procedure, that diabetics became non-diabetic almost immediately after the procedure, which we always thought that it was the weight loss that triggered the reversal of the diabetes.
You know, the endocrine system is so complex, and I feel like we're still learning so much about it. Even, you know, now we're targeting much more to the endocrine system when it comes to medical management as well. And so, yes, the gastric bypass and really any bariatric surgery, it's a combination of the mechanical effects of the surgery, but also the hormonal effects.
So how do you decide when you're with a patient for a consultation, what procedure is best for them?
Yeah, so it's very individualized. There are certain contraindications or reasons that you wouldn't do one or the other surgery. Some of those can be the actual BMI that would push you to do one or the other, depending, because they have a slight variability in the amount of weight loss. You know, there are other medical comorbidities, sometimes with very significant diabetic patients, a roux-en-y gastric bypass can be better. And age is a consideration. Follow-up is a consideration. Whereas a roux-en-y gastric bypass or any rerouting of the intestine, you know, any bypass procedure, which is a malabsorptive procedure, needs definitely a stronger follow-up because of the nutritional deficiencies that can happen. You don't want people that may be unreliable with seeking medical care.
Right.
Yeah.
Okay.
And you mentioned BMI. One of our big pet peeves in our practice is using BMI as a measurement.
Yes.
It is so flawed, and there's so many problems with it.
Yeah.
So I wish they would change to body fat percentage instead.
Body fat percentage. They've, you know, I recently did some CME on, which is continuous medical education on the new weight loss medications and just bariatric surgery also. And there was a big discussion about your circumference, waist circumference, and the body fat percentage having much more of an impact than the actual number BMI. A lot of, I think, why we end up using BMI is because that's what the insurance companies have right now as a criteria.
Because most doctors only have a scale in their office. And so it's a lot easier. But I really felt that it should be mandatory that every primary care doctor at least should have a way of measuring body fat percentage or body composition, muscle mass, and just get rid of the scales.
Yeah.
So how does somebody know if they're, I guess if somebody's not a surgical candidate? Do you turn people away for this?
Yeah, I think there are some patients, you know, depending on what the issues are. I mean, I know that bariatric surgery has been done in severely sick patients who are candidates for heart transplant besides their obesity. And then they've had bariatric surgery in order to help them become candidates for a heart transplant.
Wow.
So heart failure, severe heart failure patients who would be otherwise candidates for transplant who aren't because of their obesity. So it is done. I mean, that's an extreme kind of example. I think typically the patients who would not be candidates would be patients that have a known other metabolic condition that's treatable, a psychiatric history that would preclude them from being able to follow through with the requirements of surgery. And some of these can be like eating disorders where, and it's not well controlled.
Right.
Age can be something as well, because at a certain age, it's not really a great idea to have a major procedure. So, and I won't say a number per se, but somebody who is not fit for surgery,
well, I agree.
For general anesthesia and surgery and the long-term possibilities and complications that could really put an elderly person back, whereas a younger person would be able to manage those.
And once again, that I feel like in our practice, age is completely individualized.
Right.
Yeah. We have 92-year-olds who are playing tennis every day and golfing. And I'm like, wow, I hope I'm like that.
I did operate on a 105-year-old who swam laps every day, and she was out of, this is not for bariatric surgery, but she was out of the hospital in 3 days.
Wow.
It was amazing.
That truly is. And so what you kind of touched on, the Medicare guidelines. In medicine, we go off the Medicare guidelines. What Medicare covers, then commercial typically does too. So what are, I guess, the quote unquote guidelines that insurance allows for bariatric surgery?
Yeah. So typically it's a BMI of 35 with major medical comorbidities.
And 35 is quote unquote morbid obesity, correct?
Okay. Yes. And then the comorbidities, different insurances kind of list different ones, but typically they'll include things like hypertension, reflux disease, diabetes, sleep apnea. Those are kind of the four major ones that most insurances will list or Medicare will list.
And reflux is like GERD.
Yes.
Esophageal. Okay.
Yes.
And that, this helps people get off medications, I'm assuming, like that too, right?
Absolutely. And then the other criteria is you don't have to have medical comorbidities if you have a BMI of 40 or greater.
Okay.
Yeah. I think that as time goes on, there may be a shift of moving those things down as well, as in like having a lower threshold.
Sure.
Yeah. I know with the medical treatment, they have, you can initiate treatment with a BMI of 27.
With comorbid conditions, right?
Right.
Or
and similar,
30.
Exactly.
Yeah.
Similar to how you have a different set of criteria. Now, when you're talking about patients that are coming in to see you outside of, insurance requirements, I think typically, people can be comfortable operating on obese patients, meaning that BMI above 30. Obviously everyone's a little bit different in their surgical practice. And so, but I believe, people with a BMI of 30 and above who are interested in bariatric surgery can also get a consultation if they're working outside of insurance.
Sure.
Just because insurance has certain requirements, but
right. You can pretty much pay cash for anything these days. So if you have it,
it's always not great, but
right. Exactly. So tell us what a surgical consultation looks like, or an evaluation.
Yeah. So in a surgical evaluation for bariatric surgery, the most important thing we do is we get a full history and physical, and it's very much targeted and geared towards a history of bariatrics. When obesity started, if they have any other medical comorbidities, the psychological implications, social implications, and then, related review of systems that's related to obesity as well. As you know, obesity affects basically every other system in the body, whether it's integumentary, GYN, it increases the risk of female cancers, neuro and cardiac. And so we really go over everything in detail, find out kind of what symptoms a patient's been having, to really assess what things that weight loss could benefit if they're a good candidate. There are certain things during that help us decide an individualized treatment and give us the opportunity to offer one or the other, or, a procedure that's more fitting for that patient. And then once they've done and then we do a lot of teaching, a lot of education around what bariatric surgery is, what the process looks like, and what the next steps would be.
I remember once upon a time when we used to clear people for bariatric surgery. One of the requirements the insurance companies had was that they had to come in once a month for a certain number of months. And I remember I had a patient that it was like 6 months
Yeah.
that they had to come in, and he missed 1 month out of the 6 months, and they said, no, you have to start over again.
Oh my
Is it
gosh.
still like that, or is it better?
I think it's better in the standpoint that I haven't had a patient that has missed one and they made them start over, but there's definitely a requirement, especially when it comes to nutrition. Nutrition is definitely so important to be in conjugation with bariatric surgery. So typically most insurances require 6 visits. And then the nutritionist really decides, is that once a month? Is that once every other week? And so once we see patients, they're typically not having surgery for, 3, 6 months, maybe even a little bit longer down the line, because it is a holistic approach. If you don't have the nutritional education, you're not going to do well with the surgery, because you need to know what eating habits, which are major when you have bariatric surgery and before as well. And then with bariatric surgery, there is a change in the nutritional needs. We really focus more on protein, and then, the vitamins. And so the nutritionists see the patients pre-op, and then post-operatively as well, alongside the visits that we have with them. And then after 6 months, it becomes yearly, and then there should be following with a nutritionist at least yearly, if not more often. What can happen is, and what we do see is sometimes patients kind of fall off the wagon and then start regaining weight. And typically the first thing that we do is have them visit the nutritionist again, because sometimes it's just a matter of getting back into the habits. It's not always the case. There are multiple other reasons that people can gain weight after bariatric surgery, but that's one of the major things that it can be.
I have a background in addiction medicine, and with that came food addiction. Yes. And so I have seen in the past where people had food addiction, they had the bariatric surgery, they'd worked the program, which I do want to come back and have you touch on. Yeah. And then eventually they turn to alcohol. So their food, because they can no longer eat the food, they have to have smaller portions, and they turn to drinking. And I thought that was shocking. So I think it's very important that, as you mentioned, it's an all-encompassing approach to this. Can you tell our audience a little bit about the referrals that you have?
And more importantly, it's a lifelong decision. This is what I really try to get across in the initial consultation. It's a decision that can be life-changing for people, but that means that it's a lifelong commitment. You can't just have bariatric surgery and then just go about your day and year and life like nothing's different.
Right.
So it has to be, consultations that we typically do, and I think are very important. We do have patients see a psychologist, and one of the main things we're looking for is, food addiction or other eating disorders that can very much affect not just the surgery itself, but also how patients do afterwards and the success of the surgery. Right. And so that's something similar to what you're talking about, that one addiction turned to another addiction. And I think that is a case where it's so important for patients to continue to seek treatment with a psychologist, therapist, psychiatrist, whatever is needed. Because, depending on the situation, there are so many reasons that patients can have obesity. Some of it's genetics, some of it can be, addiction, and so many other psychological, behavioral effects too. Because it is a disease of multifactorial and affects so many systems, it definitely is a surgery that requires a committed patient who really wants this and wants this for life.
Which makes sense. And that's why I actually like the idea of them having to come in regularly for 6 months to show commitment and compliance, and accountability is also a big part, because you're not going to do surgery on somebody that is just going to say, okay, peace. And then, they
Correct.
go and do their own thing.
Correct.
And
if we get that feeling,
right.
we would not recommend surgery.
Right.
Yeah.
And that doesn't just apply to bariatric surgery.
Right.
We see so many times patients who are now on one of the weight loss medications,
Yes.
one of the GLP-1s, and they're getting it from a doctor or from someplace that just gives it gives them the medicine and nothing else, no support. And they come to us and they've lost muscle mass. You know, they may have lost some fat, but generally they're about as unhealthy as they were before they ever started.
Or worse.
Yeah.
I mean, we've seen where people actually get way worse. I'm like, you were better off, at least when you had all the fat on your body, your muscles were getting a workout every step you took, you know, but now you're just skinny fat. Now you're at risk for osteoporosis and everything else. So yeah, it's people have to understand it's all about lifestyle and changing.
And the team approach really is a big part of it.
Yes, absolutely. And, you know, there's, when we do the initial consultation, there is a full laboratory workup because you have to make sure there's no underlying conditions either. So you get labs, you get some imaging studies to look at the anatomy of the stomach. Typically, I'm doing endoscopy, ruling out H. pylori bacterial infection of the stomach. If we're going to be operating on the stomach, we should do that. And then, you know, the consultations that we talked about with nutrition and psychology. So those are kind of like the major steps to getting into, that's pre-operative, even before the bariatric surgery. About 2 weeks before bariatric surgery, then we go on a liquid diet. This is important because a lot of patients, most patients with obesity that are coming to me for bariatric surgery will have a fatty liver. And it's actually very helpful to have that 2 weeks of clear liquids because it can help shrink and decrease the mass of the liver as well. So that's the main reason we do that.
Is it just clear liquids, or do you have them on protein shakes?
That's
what I thought.
Yes.
Because I know
I'm sorry,
I've had
I
a few
misspoke.
patients.
Liquids,
it's okay.
Yes.
Yeah. Because that's what I had a patient who went for bariatric surgery, and he was on the protein shakes.
Yes.
It was like he only had one meal a day, I think it was, and the rest were like shakes. He had a whole regimen.
Correct, right.
And his liver shrank a lot, and he was losing weight during that time,
Most
which was
people
great.
lose weight pre-op as well.
Right,
Absolutely.
which is good, though. Yes. I mean, then it helps shrink some of the adipose tissue you have to go through and whatnot. Yes. I mean, and they're not going to lose too much weight to cancel the surgery.
No.
Like, not in that time period. So I know that was like a question I got asked once, and I was like, no, you're still good. This is good. Please, just keep doing what they told you to do.
Yes, absolutely.
And you mentioned fatty liver, which we've talked about in other podcasts. Fatty liver is the new diabetes. It's a new epidemic.
Absolutely.
And,
it has now become the number one reason for liver failure over alcohol.
Yeah, so we refer a lot for FibroScans and evaluations. So how long typically is the surgery?
Yeah, so I would say a sleeve gastrectomy within an hour of surgical time. You know, you always have to account for anesthesia time. And then I would say for a roux-en-y gastric bypass, I would say about 2 hours. Now, every surgeon is a little bit different. Right. But it's about that much. Now, all of these surgeries are now done majority of the time minimally invasive, whether that's laparoscopic or robotic. Yeah. So with typically 5 or 6 small incisions.
That's great.
Most people stay 1 to 2 days. I know there's been a shift to potentially doing these as an outpatient. That is not standard of care right now. A lot of that is changing. I think different areas, different states may have different requirements. Different insurances may approve for different things. So I don't want to speak too broadly, but say in my practice, my sleeve gastrectomies, if all goes well, will go home on post-op day 1, and my gastric bypasses would go home on post-op day 2.
And then generally, how long is the recovery period for them?
I would say most people would tell them that 2 to 4 weeks. And it's a combination of actually recovering from surgery, but also because of the effects of the rapid weight loss, the diet, that patients just need time to not worry about other things. So we give most people off about 4 weeks.
Do you see some of the same side effects like with GLP-1s, like nausea, vomiting, diarrhea, things like that?
We expect that patients will have nausea. We actually send patients home with a small amount of pain medication, nausea medication, and proton pump inhibitors.
And the nausea usually goes away after a certain amount of time?
Yes, it does. For a majority of patients, it goes away after some time.
I'm assuming you also want these people to eventually start exercising if they haven't been already. So
absolutely.
When do they get cleared to start more physical activity?
Yeah, so actually the first 2 weeks is just walking. Okay. We just recommend that you walk, and that's to your capacity, not doing too much, but taking it easy, but we want you walking. And typically after these minimally invasive surgeries, you can be up walking the same day. We actually, to decrease the risk of blood clots, pneumonias, it's very important to actually get up and walk the same day out of bed and walking. So
as you say, things used to be different, I remember. And so that's what I thought it was now. Like people, they want you moving. Even after I've heard of back surgery, they're up walking the same day. I'm like, wow, technology is amazing.
And then typically they'll be cleared to do more strenuous exercise and be in a program, 4 to 6 weeks after surgery.
Yeah. Wow.
And then how long do you follow these patients yourself?
Yeah, so typically the post-op course of follow-up with me would be 2 weeks, 2 months, 6 months, and then yearly after that. And basically it's yearly after that until they decide they don't want to come see me anymore. I think that's okay as long as they're seeing a primary care physician yearly and getting lab workup. So meaning that we're following... Yes, and the nutritionist, and following the nutritional labs, and that's the long-term follow-up that we would recommend.
So speaking on that, what are some of the nutritional deficiencies you see most?
Yeah, so anemia is a big one, B12 deficiency, other things we check, folic acid, thiamine, those things. The big other thing is that we always encouraging protein intake. That's another thing that's really important.
What about iron?
Yes, iron-based anemia, yes.
Iron,
yes,
okay, so iron-based anemia, not just malnutrition.
It can be a combination. Some of that is dependent on whether you've had a malabsorptive procedure. So you'll see less of those with a sleeve gastrectomy because none of the intestines is bypassed. You can still see nutritional deficiencies, and we still encourage that you still take multivitamins every day. With the intestinal bypass procedures, you definitely see more of that. We didn't touch too much on other procedures besides roux-en-y gastric bypass and sleeve gastrectomy. We did talk that the band is kind of fallen out of favor. There are a few other procedures that are done, but they're in a very small number compared to those two surgeries. But there is a duodenal switch, a SADI procedure, and I won't go over in too much detail, but some of these procedures can also have more malabsorption. They may lead to higher weight loss, but they can definitely have a higher risk of more malabsorption and nutritional deficiency.
There was a balloon procedure too.
That is newer, yeah. And, I think the long-term data is just not there to support doing it. I know people do it. Yeah.
Do you have a rule of thumb or a formula as to how much protein people should be getting?
My nutritionist does. I'm sorry, I don't have one off the top of my head, but there is formulas that they go off of and recommendations that they base that off of.
Okay.
Mm-hmm.
I typically like the 1 to 2 milligram per kilogram, but I'm a big protein supporter. I am all about protein first, and that's I'm into health there, but. So, what is there any tips that you can give for our patients out there listening for how they can prevent the weight gain from coming back? I know nutrition, obviously, and they're going to be working the program, but is there anything that you counsel your patients on?
Yeah, I mean, the main important things that I counsel my patients to do is continuing nutrition as recommended, the diet, along with that, how much to eat, when to eat, what types of foods to eat. That part is so crucial as well. The exercise plans. Those are the things that are in our power to be able to do.
Right.
Other things, our bodies they're like created to adapt. And that's one of the problems with obesity is that no matter what procedure, medication, surgery you have, it wants to go back to its steady state. And some people get weight gain and they're doing everything right, so it's not necessarily anything that we can control. Some people's bodies are just so they regain weight. I would say about 15% or so of people kind of have this expected, weight gain. We don't know who those people are going to be, but I always draw people a curve, You're going to have a decrease exponentially of your weight. And then right around 6 months or so, it kind of goes to a new steady state. And then maybe by a year out, it may be a little bit higher. You may regain some of that weight. I think that's within a normal course.
Yeah, I think it's really important to have that as an expectation. Yes. So, I mean, as we do discuss weight loss in our clinic, and we have machines and devices that help with weight loss as well that are non-invasive, like the M-Sculpt Neo. But we want people to have the proper expectation. Like if you come in and you have a BMI of 30, that device, no matter how many treatments I get you, it's not going to get you a 6-pack, you know? Right. And so that's where I think it's very important to have a realistic expectation so that we don't also affect the psyche when, you know, post-op
Absolutely.
as well.
Yes. You don't want to, we are always geared and focused on health.
Right.
And it's not the number that matters more than the health. One of the most amazing things to see is that when people get off of medications, when their diabetes is not so, when their blood glucoses are better controlled, their insulin requirements are down, they're off of 2 antihypertensive medications. Yeah. And it's just so rewarding to see that as a doctor, but also, you know, you can tell the patients just feel so much better. Most people just when they start losing the weight and past that initial like fatigue that you can get from rapid weight loss and then the diet changes, they start to feel more energy and willingness to go out and do things. And the affect and mood can be significantly different too. And it's just so rewarding to work with this patient population.
I couldn't agree more. I see it in the few patients we've had that have gone, and it's like immediate. Mm-hmm. It really, they walked in the office like a month later. I'm like, I didn't even recognize them. Yeah. There was the smile on their face even. It was just not their traditional look, you know. Right. It was amazing.
No, I think you covered everything, and I think that bariatric surgery, you know, has been pushed to the back burner because of everything else we're talking about with weight loss, with the GLP-1s and all the new drugs that are out there.
But I will say, we do know there was a grand rounds that we attended that showed the data of the efficacy of bariatric surgery versus the GLP-1s, and it was more of a long-term success.
Long-term, and we, you know, as we get more long-term data on the medications too, that'll become more clear. And I think still the bariatric surgery has a much more significant weight loss than the medication still on that comparison. I think most things, I think what's going to end up happening is it's going to be a combination approach.
Right.
And it's even more important these days to work in an integrated team and, have a holistic approach to, any chronic medical condition and our whole life and being.
Absolutely. I mean, it's, as you said, I mean, this is a lifelong journey. Yeah. So we're going to, medicine is ever evolving as well. And who knows where we'll be in 10 years from now. So it's exciting.
We're always learning.
Yes. Well, thank you so much. This was very informative. Could you go ahead and tell our audience how they can find you and where your clinic is?
Yes. So I'm part of surgical specialists of Broward and Palm Beach. We have an office in Deerfield Beach on Hillsboro. And I also have an additional office right across from Holy Cross. Should say actually our office phone number.
Yes.
Which I should have memorized, but don't.
You're in surgery. It's okay.
Yes.
Our office phone number is 954-574-0252.
Awesome. I'll also put that in the show notes.
Okay. Thank you.
Thank you for coming on. It was very nice.
Thank you.
My pleasure.
Great. The information contained in this podcast is provided for informational and educational purposes only and is not intended for the purposes of diagnosing, curing, treating, or preventing any disease. This podcast is provided on the understanding that it does not constitute medical or other professional advice or services. Before using any products or services referenced on this podcast, consult with your healthcare provider, carefully read all labels, and heed all directions and cautions that accompany the products. Information found or received through the podcast should not be used in place of a consultation or advice from a healthcare provider. If you suspect you have a medical problem or should you have any healthcare questions, please promptly call or see your healthcare provider. This podcast, including Dr. Brian Marias, Deanna Weilbacher, and Hybrid Medical Solution, do not claim responsibility for any adverse effects from the use of information contained herein. Opinions of guests are their own, and this podcast does not endorse or accept responsibility for any statements made by the guests. This podcast does not make any representations or warranties about guest qualifications or credibility. This podcast may contain paid endorsements and advertisements for products or services. Individuals on this podcast may have a direct or indirect financial interest in products or services referenced.
If you would like to submit any questions or if you have any topics you would be interested in hearing about on future episodes, please contact us through our website, www.hybridmedicalsolution.com. That is solution with no S at the end. Follow us on Instagram and Facebook, all under Hybrid Medical Solution.